Patient case, COPD and depression. Our patient, Richard Taylor, is a 54-year-old gentleman who presents to the clinic with the chief complaint of depression and, in his words, a desire to take control of his life again. History of present illness. Patient states that he has grappled with depression since his heart attack in 2015. The depressed mood has been consistently present in the last 2 months. He states a lack of interest in his hobbies, and he states he has feelings of guilt, worthlessness, and fatigue. He cannot focus at work, and he does not want to interact or spend time with his friends. He also says that the colder weather, the holidays, and being alone on his birthday have contributed to his feeling of worthlessness. He denies any insomnia, suicidal thoughts, anxiety, and shows no signs of bipolar disorder. He has tried citalopram before, and it was effective. However, he discontinued it due to the side effects of diarrhea and erectile dysfunction. He would like to restart therapy, but without the side effects. His past medical history: the ST segment elevation, myocardial infarction in 2015, COPD with exacerbation last year. However, he was not admitted but was treated with antibiotics. Obesity, smoking, and his family history is positive for cardiovascular disease and depression. Social history: he was widowed within the last year. He's an occasional social drinker but has been drinking more during the holidays, and he does not exercise. His medication list includes metoprolol ER or succinate 50 milligrams once daily, atorvastatin 80 milligrams once daily, an aspirin 325 milligrams once daily, fluticasone inhaler 100 micrograms twice daily, albuterol 2 puffs every 4 hours as needed for shortness of breath. He states that he's compliant with all of his medication. He is allergic to adhesive. His prioritized problem list: number 1, most importantly, is depression. Number 2, COPD is also high on the list. Smoking cessation, also high. Obesity is medium. And myocardial infarction is low because that he has completed treatment and symptoms are in control. Our first problem will be depression. The assessment of the disease is the patient took a HAM-D test, or Hamilton Depression Rating Scale, and scored 16. The score places him in the moderate depression category, but he also has risk factors for depression. He experienced the loss of a spouse, he has a familial history, and he has depression possibly due to his chronic disease. As far as assessment of drug therapy, he is currently not on any medication, and according to APA and AAFP guidelines, he should be either on monotherapy of an SSRI or SNRI, or combination therapy of either an SSRI, SNRI, and psychotherapy. My recommendation for this patient is to suggest psychotherapy and an SNRI like bupropion. We would start with 150 milligrams once daily and slowly titrate him up to twice a day after 3 to 5 days, depending on how he tolerated the side effects. The rationale for this is that bupropion is less likely to cause sexual side effects and is well tolerated. It also has a dual purpose and can be used as a smoking cessation tool. Patient education for this patient would include, for the medication, is to take that twice a day dose at least 8 hours apart. He should drink lots of fluid with it because it will cause dry mouth. No crushing or chewing of the tablet since it is time release. He might experience a bit of tiredness or fatigue or worsening of tiredness or fatigue till his body adjusts to the medication, and have him watch for drowsiness. He should avoid alcohol while on this medication because of the drug interaction with alcohol, and also because alcohol worsens depressive symptoms. Patient's follow-up and monitoring would be 4 to 6 weeks after initiation of therapy to see if there is a change in the patient's mental state, and to see whether the medication is effective or not effective, or whether we need to make adjustments to the dose. We will need to tell the patient that it will take at least 4 to 6 weeks for him to see a difference, and that care for depression could last up to a whole year. Our second problem would be COPD. The assessment of disease is that he has no visible signs of breathlessness upon rest, but complains of mild shortness of breath upon exercise. He has no bronchitis. His CAT score is 21, which indicates a high impact on his quality of life, his everyday activities. His FEV1 over FVC, or forced expiratory volume per second over forced vital capacity, was 0.63. Per the GOLD guidelines, if anything is less than 0.7, it indicates a restricted airflow in the lungs. He also has, per GOLD guidelines, an MMRC dyspnea scale of mild. So his current drug therapy is fluticasone 100 micrograms twice daily and an albuterol inhaler every 4 hours if needed. The short-acting albuterol or a beta agonist is not controlling symptoms. Per new GOLD algorithm, long-acting beta agonist might be a better option for this patient. So my recommendation for this patient, per the GOLD guidelines, is to consider a combination long-acting beta agonist and an inhaled corticosteroid. My choice would be the fluticasone vilanterol once a day. My rationale for therapy is that it has been shown to improve lung function and reduce symptoms. Patient has already been on once-a-day dosing on his other medications. This will increase adherence. Monitoring for this patient would include changes in CAT score and dyspnea index and changes in his FEV1. We will also discontinue the fluticasone since he's going to be getting that in the combination. I would also keep the albuterol on board for breakthrough episodes. As far as patient counseling, we should include smoking cessation as an important part of speaking with the patient. Smoking is an exacerbating factor and also a cause of COPD. Patient has shown an interest in discontinuing smoking, so we should encourage that. If he tolerates the bupropion, with appropriate counseling, we should be able to get him to cease smoking. If he feels he needs a crutch, we could consider the patch. However, we will have to keep in mind his allergy to adhesive. Should he tolerate the adhesive, we would want to remind the patient he cannot smoke while using the smoking patch. While using the inhaler, we will remind the patient that he should rinse and spit after use to prevent development of thrush, oral fungal infection. Most of the oral inhalers are well tolerated. However, long-acting beta agonists can sometimes cause changes in heart rate, and the patient needs to notify his care team should that happen. And he should also notify his care team if the long-acting beta agonist is still not covering him for shortness of breath upon exercise. Thank you.